All right. Hello and welcome, everyone. This is Caleb from TAC at the National Rural Health Resource Center. Today is Monday, May 4th, and this is our May TAC Virtual Knowledge Group call. Today we have May Kwong from the Center for Connected Health Policy. She is the director of the Center for Connected Health Policy. They are dedicated to integrating telehealth virtual technologies into the healthcare system through advancing sound policy based on objective research and informed practices. They serve as an independent center for excellence in telehealth policy, providing technical assistance to 12 federally funded regional telehealth resource centers, state and federal policymakers, national organizations, healthcare systems, providers, and the public. We're very excited to have May here to share more about the recent work and resources that they have available. We also have Dr. Kevin Steffen. He is a board-certified infectious disease physician with many years of clinical experience. Recently, he has been serving as the Director of Strategy and Planning for NOD Specialists, a telemedicine-based infectious disease practice headquartered in Phoenix, where he sees patients live and via virtual video throughout the United States. Prior to this, he was a chief medical specialist and chief of infectious disease for St. Mary's Medical Center in Duluth, Minnesota, as well as he had a 23 career in the United States military, serving in multiple roles as a physician, researcher, and educator, including running the HIV program for the United States Air Force in San Antonio. He's deployed after September 11, 2001, and participated in humanitarian operations and relief in Africa and Central America. So join me in welcoming both of our speakers today. Our topic today is telehealth. It's a little different than our normal virtual knowledge group calls where we have presenters, but with the current pandemic, we thought it'd be great to have experts who can speak about the waivers and changes that are happening right now. So please do take just a moment to complete the polling questions as you get logged in, but we will get started in just a second with May Kwong from the Center of Connected Health Policy. Thank you, guys. All right, May, if you are there, your arrows should be on the bottom left for you to advance your slides. Otherwise, if you just holler out slide, we will advance those for you.
Okay, it's just uploading right now for me. There we go. All right. Thank you, and thank you for having me here today. As the introduction said, I'm May Kwong with the Center for Connected Health Policy. Before we get started, I always have to start off with some disclaimers because we are primarily grant funded. So any information provided today is not to be considered legal advice. It's purely for informational purposes. CCHP always suggests that you seek out legal counsel if you're looking for a formal legal opinion. And if I happen to mention a company or show some type of product, please know that neither I nor CCHP have any type of financial arrangement or relationship or affiliation with such a company. So a little bit about CCHP. We were actually established in California in 2009 underneath the Public Health Institute as a California telehealth policy organization. An opportunity to become the federally designated National Telehealth Policy Research Center became available in 2012, and we applied through HRSA for that grant, and we received it, and we've been working in that capacity ever since. We also do other work with a variety of partners on more specific projects, and that's just a listing of some of the partners we work with. Some of the projects that we are currently working on, we do a 50-state report on all the telehealth Medicaid policies, laws, and regulations for all 50 states and DC. We also track the federal information as well. We also act as the administrator of the National Consortium of Telehealth Resource Centers, and I'll explain a little bit about that in a moment. And we also convene a coalition of over 70 statewide organizations in California that are interested in telehealth policy for the state. So I mentioned the National Consortium of Telehealth Resource Centers. There's actually 14 of us. There are 2 national resource centers. CCHP is the one on policy, and there's one on technology. And then 12 regional resource centers that cover specific states. They're more of the program operational level, boots on the ground folks, so people who have questions regarding telehealth, how to start a program, or how to enhance the program they have, they usually reach out to the telehealth resource centers with specific questions regarding that. We also work very collaboratively together, so much so that we've formed this consortium of National Consortium of Telehealth Resource Centers in order to make sure we use our funds efficiently and effectively and to cut down on waste and duplication of work. So if you have a question regarding telehealth, I always suggest you reach out to your regional telehealth resource center first. But know when you do that, you're actually getting the other 13 helping as well, because as I said, we all work very collaboratively together, and we share information or try to find information that maybe one person doesn't have knowledge of. Usually one of the other 13 does. I mentioned also that CCHP tracks all of the Medicaid policies, laws, and regulations related to telehealth, and we do this twice a year. So as you can understand, it's a pretty hefty undertaking. Our report averages around 450 pages, maybe a little bit more, of all this information. And we do updates in the spring and in the fall. Actually, when COVID-19 hit, we were in the midst of our spring update, and that should be really soon. However, the information will only be updated up to February of 2020. A lot of the information related to COVID, it's been temporary. It's done through executive orders. We have that on a different section of our website. As I said, that'll be updated in a few weeks. Currently, what's on our website is information good through October 2019. And if you have a specific interest in a state, you can just search by that state and not have to wade through all of the information for the other states as well. So that's an interactive map. It's an actual picture of our website. You can just click on it and it'll bring up the information. So this is slightly the translation from my PowerPoint to Andrew, I think, may have messed up the formatting a little. So feel free to share the PowerPoint afterwards. So it's a little hard to read some of the bottom stuff. But as most of you know, there's been actually quite a bit of movement on telehealth policy over the last couple of weeks even. So telehealth policy, you have to look at it both on the federal and the state level. As on the federal level, it's primarily centered around Medicare, though there are other policy issues that impact telehealth. And then on the state level, it is around Medicaid, private payers, and again, other policy issues as well. But those are kind of the big buckets of where a lot of recent action has centered around. The majority of it has really been around the reimbursement of telehealth, what can get paid if you use telehealth. And a lot of attention has been paid on what's been going on at the federal level, primarily because of Medicare. And also one of the reasons there's been so much action on the federal level and in Medicare is that prior to COVID-19, Medicare actually had one of the most restrictive telehealth reimbursement policies out there. So they actually needed to implement a lot of changes in order to make it more widely accessible to more people. So a lot of the limitations that centered around Medicare reimbursement around telehealth is embedded in federal statute. So you need a congressional action in order for that to be changed, in order for some of those barriers to be lifted. And it was, as I said, around reimbursement, but there were 4 sort of issue areas in how they limited the use of telehealth, and they were around location of where the patient is, the modality that's used, the type of provider who can provide the services, and the types of services that they will reimburse. And for the most part, most of those restrictions have been lifted. There were changes as recently as last Thursday that lifted even more of those restrictions. So what we currently have underneath Medicare is that the geographical limited ways prior to COVID-19, you needed to be in a very specifically defined type of geographical location in order to receive telehealth services. And that was rural or non-metropolitan statistical area with a specific definition for rural. And that's been waived. So geographically, you can be located anywhere as long as it's within the United States. Site limitation, again, it was a very specific list of sites in which the patient could be located, usually like some sort of medical facility, like a clinic or a hospital or a doctor's office. Very, very narrow exception for the home pre-COVID-19. Again, that was waived. A lot of people are sheltering in place at home, so they recognize we need to open this up as well. The provider list, and this is one of the more recent changes that came out last Thursday. There was a very specific list of providers who could be the actual telehealth provider providing that services, and it was very limited. Pre-COVID-19, it did not include federally qualified health centers and rural health clinics. It did not include some of the allied health professionals like OTs and PTs. As of Thursday, that's been waived, and basically it's any Medicare eligible provider who can provide a service and they're acting within their scope to provide those services. They can be an eligible provider. Services that are eligible. So the services that are eligible is a very specific list, and they go by actual CPT or HCPCS code. They did expand that. They added another 80 additional codes to bring up the number of services that they will reimburse if it's delivered via telehealth to about 190. So still not a big list, but it is more than what they were doing pre-COVID-19. And interestingly, they have offered up a way in which they will consider adding more codes to that list, eligible codes to that list. And they used to have this other process pre-COVID-19 that was kind of hard to get a code on there, but they've essentially said now, if somebody submits a request to add a code, we'll consider it, and then we'll just add it without having to go through a regulatory process for comments, etc. Modality, that was the other one. Basically, pre-COVID-19, it was just live video. Unless you were in Hawaii or Alaska, then you're allowed to use Store and Forward. Phone was something that a lot of people requested because not everybody has access to technology when they're at home. So they did allow the phone to be used for some services as a way of delivering services, and that went into effect last Thursday as well. And then some of the other types of changes that they were allowing, supervision requirements, they're relaxing some of the licensing requirements within the Medicare program. They're relaxing that, and then some visit limits. There were some areas where they said that you can only do so many telehealth visits in a certain period of time. Like, for example, skilled nursing facilities pre-COVID-19, they said only one telehealth visit every 30 days. They've waived those limitations. It's a little difficult to see because the formatting got a little bit off, but one other thing to understand with Medicare, and when they reimburse for technology-delivered services, they have two buckets. A bucket that they call telehealth that faces all the statutory restrictions that I talked about earlier, and then another bucket called technology-enabled services or communication-based services that use telehealth technology, but they don't call it telehealth, so it's not underneath the same restrictions that telehealth services are. So these technology-enabled services include your remote patient monitoring, other services you can do by phone, but other services you can use with telehealth technology like live video and Store and Forward as well. And that's where you have your virtual check-in codes, your chronic care management codes, etc. A couple of other things on the federal level that they did change as well, or that were policy things that impacted telehealth, is with the DEA and prescribing controlled substances. When you prescribe a controlled substance, that is controlled by federal law, and there's a narrow band of exceptions where you can use telehealth without having an in-person exam. One of those exceptions is when a public health emergency has been declared, so that is kicked in, and you can prescribe via telehealth a little bit more easily that way. And then the relaxation of some of the HIPAA requirements as well. Basically, OCR saying that, they'll exercise discretion and they'll be unlikely to fine people for violations during this period. I do caution people saying, they said it's a guidance that they'll exercise discretion. There's no guarantee that they may not decide to go back and possibly fine people. So just to keep that in mind. On the state issue, we see a lot of changes that mirror what we saw happening with Medicare, in that they're allowing certain modalities and location exceptions as well. So on the state level, we're seeing a lot of common things, such as allowing the phone to be used, which was very specific because a lot of states explicitly prohibited the use of phone underneath the telehealth definition. So they're allowing the phone to be used as a means of delivering services, allowing the home to be an eligible location. Again, a lot of states have prohibited that or only allowed it for a narrow band of services. We're relaxing some of their consent requirements, also expanding their list of providers, relaxing some of their licensing requirements because licensing is controlled by the state, and expanding the list of services in which they can use telehealth in order to provide those services. Here are some of the federal policies, links where you can go and look at some of the Medicare and DEA changes as well. And then I also wanted to point this out. HHS came out with a telehealth website a few weeks ago. So this is information for both patients and providers. So I just want to include this link on there as well for folks. And then the CCHP links that we have. Like I said, we are tracking the federal policies as well as like what's going on at the state level. We also do a weekly newsletter as well. I used to say it's once a week, so it's not that burdensome, or you're not getting a bunch of stuff from us every week. I can't guarantee that during this time, because when something new and breaking, like the changes in Medicare that came out Thursday, come out, we are sending out an alert letting people know that this recent change just suddenly came out. But you're more than welcome to subscribe to it if you're interested. And that is it. Thank you.
Great, thank you, Mike. Do we have any questions for May? Star 2 will unmute your line. Again, to help address some of the background noise, Star 2 will remute your line if you're not speaking. All right, we are ready for you, Doc.
Okay, I just had to get to my starting slide because it popped open in the middle of the presentation. So,
yeah.
All right. Well, I am Kevin Steffen, and I'm an infectious disease physician, and I'm really pleased and grateful to have the opportunity to present to this group. My connection was that I established a relationship with Telehealth through the National Rural Health Research Center, who then in turn put me in touch with Caleb and Andrew, and we've been communicating back and forth. And so I've been looking forward to this opportunity to discuss telemedicine in rural settings, which is an area that I'm intensely interested in. Nod Specialist is focusing on rural relationships and rural partnerships, and so it's a topic that I think is something that I can speak to. I just wanted to also thank the former speaker, May Kwong. Basically, I can tell you as a practitioner who's using telemedicine in a rural setting, state by state, the CCHP has been invaluable, and their resource in terms of providing guidance on the regulations. It would be impossible to keep track of these regulations, I think, otherwise. So hats off to their organization. They do excellent work. All right, well, I wanted to talk today, topic in hand. Of course, everybody's concerned about COVID, and I can tell you that the main thing I've seen is that COVID is making it so that many rural facilities are eager to talk to me when I come to them knocking and say, hey, I'm doing telemedicine, might you be interested? And that wasn't necessarily the case 6 months ago. So I think that there's been a lot of increased interest and receptivity towards telemedicine and some of the unique roles that it might play in delivering specialty care in rural settings. So I'm going to advance the slide here. So that's me. As it was mentioned in the background, I've done infectious disease care for a long time. I previously was in the United States Air Force. I'm currently the Director of Strategy and Planning, and I also continue to actively see patients on a daily basis. In fact, I spent this morning rounding virtually in a hospital in Colorado, and then I saw a outpatient clinic patient who was concerned they might have COVID, and we talked them through the symptoms and what was going on there. But I'm a physician. I'm not a lawyer. I'm not a legal expert. So anything that I bring up, kind of like the disclaimer slide that you saw in May's presentation, I don't pretend to be an expert on reimbursement, telemedicine status, but some of these really positive changes that have happened in the field of telehealth and telemedicine surrounding COVID, we don't know what their durability is going to be after the pandemic passes. We can only hope that some of these rules will stick because they really have facilitated providing specialty care in rural settings. So what I see as the benefit for telemedicine in rural healthcare and rural hospitals is increasing access to service lines and specialties that previously weren't available. There's a critical shortage of healthcare providers in rural areas, and when you get beyond primary care into the specialties, it's even more acute. Some of the hospitals and facilities that I'm partnering with right now, they really enjoy the fact that the patients really enjoy that they can stay in their local community in the hospital that they're comfortable with and have their family at the bedside, and have the specialist come to them rather than have to go travel a long distance to seek specialty care. And also because of the fact that we can provide backup and continuity and have redundancy built in with multiple physicians that can help, there's no disruption of care due to paid time off or illness. And then, so there's increased access, there's the cost effectiveness piece. If you think about recruiting a provider and then paying malpractice insurance, paying their health benefits, paying all of the salary and all of that versus using an on-demand service where you access the care when you need it, it really can prove to be cost effective. And then from the patient standpoint or from the facility standpoint, reducing medical transportation. I have had doctors say they previously would have had to put a patient in a helicopter and fly them a long distance to the major metropolitan area, but rather now they can just ring me up on the phone and we can schedule a video visit and we can do a consultation that way. And then another thing is that if the facility can say, look, we're embracing technology, we're not running the other way, we can offer these service lines that previously we couldn't and that many facilities of our size can't offer. That adds some prestige to the facility and their ability to, as they talk to their community about the services they can offer. You know, there's, in my own specialty, which I know best, infectious disease, there's about 7,000 of us in the United States. It's a pretty small specialty, and over 90% are, probably more like 95% are in major metropolitan areas. And so if you get 25 to 50 miles outside the radius of a major metropolitan area, it's very challenging to find specialty care. And so why this is important is specialists can provide a level of expertise that might not otherwise be available. And there's a lot of clinical and medical studies that have been done that show that for diagnoses that are in their specialty, patients do better if they are seen by a specialist versus a generalist. For instance, Staph aureus bacteremia, when treated by an infectious disease specialist, has less morbidity and mortality than if it's treated by a generalist. But in order to roll out a successful telemedicine program in a rural area, there's some certain factors that should be looked for and that will predict the success of the program. You're better off sticking to highly qualified providers. You don't want to have questionable credentials. You know, when we go into facilities, we become a credentialed part of the medical staff, and then that way we can work with our provider colleagues and become a part of the community. And they also, when we're also available if they have questions, they can text or call us with questions. And this allows us to be an established resource in the community so that not just in the acute care setting, but in the post-acute, long-term care facilities, and even in the patient's homes, we can continue to follow the patients across the continuum of care. Also, as you're looking for telehealth or telemedicine technology, something to be aware of is that some services require purchasing an expensive device, a big robot type of a device that has to be purchased for thousands of dollars. A more desirable approach, in my opinion, is if you can have access to the video platform through the internet, through the web, and if you could access it through a smart device like a tablet or a laptop or a Chromebook, as long as it's got a webcam and a microphone and speakers, you know, you should be able to do video telemedicine, or just with telephone even, you can do visits, as was mentioned by May in her presentation. So what am I seeing in COVID-19 and its impact on telehealth? Well, there's the patient care aspects. I mean, for sure, I've been helping and advising facilities on personal protective equipment, PPE, like N95 mask use, testing of patients, cohorting and isolating patients. So there's the clinical piece for sure. And then also the fact that, you know, people are wanting to get the answers about whether they could be infected with COVID-19, and potentially they're putting other people at risk if they have to come into busy waiting areas, come into their rural ER hospital setting. And so there's been a strong push to try to screen people before they access care in person, and perhaps figure out virtually whether they could be at risk for having COVID-19 and where they could get tested and how they can follow up. So there's that whole clinical piece that I think is important, but for the non-clinicians, I think it's important to realize that this pandemic has really been instrumental in driving a lot of executive orders and other regulation changes that May outlined very nicely. And again, I'm not an expert, but I can tell you that if you look at the state medical boards and go to their website, the Federation of State Medical Boards, you can see updated status of licensure requirements, and we've seen quite a bit of changes in terms of relaxing the requirements for in-state licensures. The Center for Connected Health Policy, again, there's telehealth coverage policies during the COVID-19 emergencies. CMS has a telemedicine toolkit for providers, and so there's lots of resources out there and lots of changes afoot, and quite honestly, it's kind of dizzying, the pace of change. Every week I'm getting some updates in my feed on changes that are being made and modifications, and most of them are very helpful for practitioners and for patients. And so I'm hoping that, along with many others, that these changes will be durable. Okay, so since May kind of covered this in her talk, I'm going to just briefly kind of highlight what I think as a clinician, these rules for telemedicine and some of the important changes that the federal COVID-19 response has led to. Importantly, before there were a lot of restrictions on where you could provide telemedicine and where the patient was housed and where the provider was housed. And right now, telemedicine access has been broadened such that all settings, and that's rural and urban, not just rural areas, including physician offices, hospitals, nursing homes, and rural health clinics, and even in the patient homes. Right before I logged on to do this webinar, I had a COVID-19 patient appointment, and it was conducted in the patient's home, and that was very convenient for the patient. The problem with telemedicine and why a lot of the health systems and providers were slow to adopt it is that there was not parity with reimbursement. You could expect to get not paid at all or get paid significantly less if you offered telehealth compared to a standard in-person visit. And those rules have definitely improved the compensation and reimbursement for telemedicine delivered care relative to in-person care. And so that's a favorable change. Previously, too, you could see a patient for telemedicine if you could document that you had previously established a relationship with the patient. They didn't want telehealth providers to be reaching out and acquiring new patients that were not known to them and seeing them by telehealth. If you had seen somebody in the office and then you wanted to do a follow-up visit by telehealth, that was permissible. But now, especially with COVID patients, many of these may not have established care with any primary care provider, or if they had, they're not an infectious disease specialist. And so we're able to reach out now and see people who we didn't have a prior therapeutic relationship with and help them via telehealth, which has been a great asset. In addition to Medicare kind of driving the boat, a lot of state governments with Medicaid and then the private insurers are also following along and taking their lead from Medicare, as they often do. May mentioned the HIPAA waivers, the fact that there may be ability to use video platforms like Skype and Zoom to communicate with patients and to do video visits. The problem with that is that you want to make sure you stay away from public-facing platforms like YouTube or Vimeo. If it's publicly accessible, it really is going to be a problematic situation for the patient privacy. And my feeling is, and I think many of us in the field believe that privacy is still important. And my advice to colleagues and others in the field is that you try to stay with HIPAA-compliant video solutions whenever you can, because this is really kind of a try to get as many visits out there as possible and increase the capacity by using Skype and Zoom. But in the long run, we don't know how they're going to enforce this relaxed guidance, and I would recommend that we stick with the HIPAA-compliant video. So when we look at the lessons that we've learned from COVID, and clearly it's not behind us yet, and we're still learning, but the American Medical Association, a large national group, really said it well, in my opinion. They said that rapid adoption of telemedicine is a key strategy to limit COVID. It allows patients to communicate with their healthcare providers without leaving their homes or their community, and this can reduce the strain on burdened healthcare facilities. You see the pictures of the exhausted healthcare workers taking off their N95 masks after hours in the trenches, and a lot of that can be reduced if you're doing telemedicine because you're helping the patients in their home environment where they're not having to come into crowded ERs to seek care. Telemedicine can safeguard the staff and reduce demand on PPE. Again, I was rounding every day on COVID-19 patients, and I was the only member of the care team who didn't have to don a N95 mask and a hood and a gown. I was able to do it virtually. They did put it looked like a cellophane wrapper over the video to keep the screen cleaner so they didn't have to scrub it between every patient. But, it was basically, that was one less person that was using a lot of PPE and putting themselves in harm's way. What we're finding is that there's variable acceptance for using telehealth, and that can be based on where you live, whether you're in an urban area or a rural area, and the age of the people you're asking. Younger people tend to be more willing to consider using technology, whereas some of the people over the age of 55 are a little bit more reluctant to consider it. And then there are some ongoing broadband connectivity issues in rural areas. I know in Arizona, our rural health telehealth group is actively advocating to get broadband into many communities that currently don't have it. And I'm sure that there are similar discussions underway in many rural parts of the United States right now. So I'd like to just leave you at the end here with a telemedicine case study. This is basically true. We removed the names to protect all parties, but this was one of the facilities that my organization and myself, we partnered with. And this was a busy rural facility that was struggling for a couple of years. They've been trying to recruit specialist physicians in infectious disease. They were a well-respected facility. They had lots of other specialty representation. They had high volumes. It was a desirable place to live, but they just couldn't attract a full-time infectious disease physician. So they explored using virtual care and telemedicine as a short-term solution. Their thought was, if we can get this in place, it might be a bridge to finding somebody who might be willing to work with us and be an actual physician in our community. They partnered with us, and we started seeing patients for them, both new consultations and then follow-up visits, and then saw the patients once they were discharged from the hospital. The patient satisfaction scores significantly increased because the patients, again, could stay in their community. They could see a specialist. They could have their family at the bedside. They didn't have to have the disruption of traveling to a metropolitan area to receive specialty care. The patients were getting out of the hospital faster and were having lower rates of readmission, and that was, of course, making the administrators in the hospital happy in terms of not having those problems with readmission rates. The patients felt like their facility was really kind of a leading edge facility and really we're talking it up in the community. And so when I would start seeing some patients, they'd say, oh yeah, we know somebody who used your service and they thought it was really interesting and really cool. And so now, because of that, they're kind of taking the heat off of trying to recruit an infectious disease physician, and in fact, they're talking about integrating and incorporating telemedicine as part of their long-term strategic vision. So now we're a critical part of the team. We are credentialed members of the physician provider staff. We document in the facility's electronic health record for good communication. We can also communicate frequently with the medical provider staff via cell phone, and we also use a HIPAA-compliant texting service. And then we coordinate with the facility's billing office to bill the patient's insurance for services that we provide. And then we've established relationships with the surrounding post-acute facilities as well, the skilled nursing facilities, the long-term care facilities, and again, in the patient provider offices in the primary care setting. And that way we can follow the patient once they leave the hospital, whether they go to a skilled nursing facility for rehab, whether they go back to the long-term care facility where they came from initially, whether they go back to their home. We can follow them and make sure that the plan of care that we put into place has been effective and that they're not going to be at risk of developing a relapse and getting readmitted. So it's been a really good relationship. Just a bit about my organization. We were founded in 2018 by board-certified infectious disease physicians. We're adding other hard-to-recruit subspecialties such as allergy, immunology, nephrology. We're going to be adding rheumatology, endocrinology as well. We do have a web-based software application that's accessed through the internet, and we've made it so that it can run on an inexpensive laptop or a tablet. And we also provide services like antibiotic stewardship and infection prevention as needed. So we have a board-certified infection preventionist who helps. In fact, a couple weekends ago, we took the weekend and rewrote the policies surrounding personal protective equipment with COVID because they were burning through their N95 masks and they wanted to know about sterilization of masks and things like that. And so we were able to help them in real time come up with some policies that allowed them to extend their supply of personal protective equipment, and they were appreciative of that. And we also could help keep their frontline staff, such as the nurses in the ICU, the surgeons, and even the OBGYNs who had questions surrounding doing vaginal deliveries and C-sections in the era of COVID-19. So there's a lot of things that can be accomplished by telemedicine that you don't need to have an in-person specialist for. So basically, that's the end of my prepared remarks. I wanted to make sure that there was time for questions, and so I didn't want to overburden you with too many slides. So at this point, I'm happy to stop and listen and take any questions that you may have.
Yeah, great. Thank you very much, Dr. Steffen, and as well as me. So I'll open it up to everyone for questions. We've got a couple different. I know we've got one question already on the books that we'd like to ask, and I know we wanted to just have some discussion as well, focused on what Flex programs are doing, are changing some of their efforts related to telemedicine and COVID response. But let's start with some questions. I do want to make mention real quick that last point, Dr. Steffen, about helping hospitals identify opportunities to change their processes and procedures. You were speaking specifically about sanitation and personal protective equipment right now, but that's something that can be done and is really beneficial in the telemedicine world, especially when you have an infectious disease doc who you're working with. But the antibiotic stewardship programs and efforts have great outcomes and have really good results, and it's a project or a program that works really well telemedically as well as working with infectious disease docs. And there's a lot of opportunity there for improvement in health and well-being of the community on just that one topic. So I want to make sure I put a little plug there.
And that was really a question, right? You don't want me to reply. I appreciate the plug, because I agree that antibiotic stewardship is very crucial. It's been in large metropolitan areas, but in rural facilities, we're finding that the impact can be just as important regarding reducing the antibiotic selective pressure for infections like MRSA and C. diff, and squandering the antibiotics that we have so that they are less helpful and less useful. And so, yeah, I mean, in fact, if anything, smaller facilities could even be more impacted because the pharmacy budget can be a fairly large part of the cost of care. And if you can have efficient use of antibiotics and really steward them correctly, you really can end up making sure that the right patient gets the right antibiotic at the right time and that you're not overusing your antibiotic resources.
Absolutely. Yeah. So thank you for that. We did get a couple questions come in. I will start with addressing these in the chat box real quick. Thank you, Kyle. And then Nicole, I'll let you go ahead. So Kyle says the discussion we hear is if and how small rural hospitals will include telehealth in short-term and long-term strategic planning. So short-term with the COVID environment and then long-term as a continued practice. Can you speak more, Dr. Steffen, about kind of strategic planning for long-term and telehealth use beyond just the emergent or urgent need right now?
Absolutely. You know, I think that as I talk to leaders, every day I'm on the phone with leaders of rural hospitals and health systems, and you know, a lot of them are, you know what, they say call me back in 2 months because we're up to our neck in alligators right now with COVID, and so you know, there's the whole contingency mentality that you've got to get something on the books right now, that you need to be able to reach the patients who are running scared with COVID, and that we don't want them overwhelming our resources in terms of our ER staff and our clinics and whatnot, and so I understand that, but I really think that where telehealth needs to go in rural settings is to become a permanent fixture and to be a partner to be able to really leverage the technology, because the shortages in specialty personnel, in providers, staff, they're not going to get better. They're only going to get worse. The median age of infectious disease specialists in the United States right now is 55, and a lot of them are heading for the exits right now because of the burnout and that kind of thing. And so the number of new people coming in isn't even keeping pace with the number retiring. And so I don't see this problem getting better. And so I think we have to get smart about how we are going to try to address shortages in specialty care. And it's not just infectious disease, it's a lot of specialty services that could be effectively delivered in a very cost-effective means by telehealth. And so, again, sometimes facilities are going to partner with large integrated health systems, and that's one way to do it. Other times they might try to look for individual relationships with other smaller practices. Again, what I would say is that in the terms of the strategic planning, there has to be a corporate will, meaning that there has to be a top-down or sometimes a bottom-up. Sometimes I talk to the providers and they say, well, you know what, we could really use this, but the administration is kind of reluctant because they're afraid that it might impact their bottom line. And then other times I talk to the administrators and they think it's a great idea, but the providers are kind of indifferent because they say, well, we've been managing these problems by ourselves for years. We don't really need that kind of specialty help. And I guess my argument in both cases is that there's probably some short-sightedness there, because I think in the long run, in order to remain able to provide care for the community, that as telehealth becomes more accepted, people are going to want it and expect it, and I think that that's going to be a really nice and a cost-effective way to access specialty care in a lot of rural health settings that can be done very cost-effectively. It doesn't have to be a budget-breaking exercise for these facilities. And a lot of the CEOs are very nervous about, well, what's the equipment cost up front? And as I demonstrated in my slide set, it really can be pretty low-tech, a $300 Chromebook, or something like that. So.
Great. Thank you very much, Doctor. Nicole?
Yeah. Hi, Caleb. Thank you. I had a question from Laura Brooks in Oklahoma. She is wondering if we or all of you on this call are aware of telecardiac rehab happening in rural areas. I could tell from a Google search that it is a thing that happens, but I did not find it in a small hospital. So I'm just wondering if anybody on the call is aware of telecardiac rehab in their states in rural areas. And while you all ponder that, I think this question, the next part of the question would be for May from the Center for Connected Health Policy, if that is reimbursable by Medicaid currently, and if that is a COVID flexibility, or if it's something that was previously allowed.
Did you say Medicaid or Medicare?
Medicare.
It would depend on, and I'm not familiar with the services and how they would bill them. It would depend on if those services were on the list of eligible codes that they are reimbursing for. So as I said, it would depend on the exact CPT or HCPCS code that they were billing for those types of services, and if it was on the list that would exist pre-COVID-19, then it would be like, yes, they're reimbursing those via telehealth, and those should stay. Once this emergency passes, if it's on the list that came out with the 80 additional codes that I mentioned in reaction to COVID, at this point, those are temporary during the public health emergency. So depending on what codes specifically they're talking about.
Sure. Laura, did I ask your question right? Did you have any follow-up questions to that? Or two to unmute your line.
That was great. That was our exact question. So if anyone else has similar programs in your state, though, I would love to hear about them. We had a hospital CEO reach out to us with this question. So thank you all.
And then, like I told you in our private chat, you should probably have that hospital reach out to Heartland. That would be the Telehealth Resource Center for your region, to see if they can help a little bit more with that specific coding stuff, and answer some questions about that so they can get it going.
Thank you very much. What other questions do we have for Dr. Steffen or May?
This is Terry. Hi. I don't have a question, but I want to make a comment, and that is, according to a recent study by Stratus Health, so our folks know Stratus Health, and what Stratus Health did is they brought their big health systems together into a committee, and basically they had the 9 Minnesota healthcare systems, and surveyed them in terms of the number of telehealth visits they were having, the 9 systems were having prior to COVID-19. Luckily, they'd already put the group together, so they had that data. And literally within 2 months, certainly it might even been quicker than that, the number of daily telehealth visits by those 9 systems increased from around 1,100 a day to well over 14,000. So it was an increase of 1,350%. And that's we are changing the way we practice medicine in this country, and I believe firmly, you get my opinion here, we're not coming back from that. We are offering our people, instead of having to come into the urgent care centers and having to come in to think about it, we're going to be, we're going to be reluctant to go into our medical offices and hospitals unless we're really sick here. And we're already seeing evidence of the fact that people are staying home rather than going in. So when we have available to us this very convenient way of getting health care, it's going to drive telemedicine big time here. And I just want to express my concern that it's extremely important that rural hospitals really explore their use of telemedicine, and not just using outside specialists like Dr. Steffen, but also thinking about the work that they can do from their hospitals and clinics into the patient homes themselves. And one of the provisions in the CARE Act basically provided a capability of rural health clinics to actually see patients in their homes. And rural health clinics did not have that capacity before. Now they have it, at least temporarily. And so they have this method now of reaching out to the patients. And I guess my concern is, if we don't respond to this as rural providers, rural hospitals and clinics, in essence, there could be other providers. I can mention Amazon, I can mention the big health system that happens to be nearby, could be coming in there as well. So I really think that this topic of telemedicine is extremely important for our rural hospitals, and that's why I think this particular session that we're having right now with the VKG is so important.
Yeah, I couldn't agree more. Anyone else have comments on that? I definitely think it's the way of the future. As I like to say, it's 2020. We're supposed to all be wearing silver jumpsuits. So I like that we're at least talking with each other face to face. One of the phone calls I had with Dr. Stephan, we did it via video chat to introduce each other. It was great, and I like that. Got a question coming in from Kyle. The word from some providers is they don't get into medicine to do telehealth. Some providers are reluctant to look at telehealth long term. Have you had any experience with that, Dr. Stephan, of providers not wishing to utilize telehealth? They want to lay hands on patients.
Well, there certainly are some concerns that you could degrade the patient-physician experience if it's not done properly. That's one concern I hear. And it's like, well, if I can't lay the hands on the patients, then how am I going to provide good care? And I have to say that I had those same concerns when I went into the area of telemedicine. But really, what I started, I flipped that around, actually, to be honest with you. And what I said was, all right, these are sites that previously didn't have specialty care, and even if sometimes I have to adapt my approach because I'm not able to put hands on the patient directly, maybe I have to ask the ICU nurse to put his or her stethoscope on the patient's lungs, tell me what they're hearing, and then I work with that plus the chest x-ray and the CAT scan to figure out what my next steps are going to be. Maybe I have to get a little bit more creative in some of those types of ways, or maybe I have to have them put the video camera on the patient's leg so I can see if it truly is a cellulitis that's getting better versus some other problem. Those kinds of things. So you have to be flexible and you have to be willing to work. But ultimately, what gets me up each morning is the idea that I'm rounding in facilities that otherwise wouldn't have specialty support. And so even if the care is a little bit felt to be it frightens some people because of the technology or the intrusion into the patient-physician relationship or whatever the concerns might be about not wanting to do it. I feel like as the shortages get more and more and more oppressive in healthcare and we don't have enough specialists to go around, this is a very efficient way to leverage the expertise and to get into to see more people and give them the help that they need and that they deserve. And so I will say, though, flipping it around, as I reach out to physicians to grow our practice, and I'm talking on the phone all the time to infectious disease physicians, there are two big groups. There's one group that says, you know what, I don't want anything to do with telehealth. And then there's another group that says, I've been thinking about doing this for a couple of years, and this is just the nudge I needed. And so I've hired 7 telehealth-friendly infectious disease physicians to my practice just in the last month or so because there's people that are having this pent-up demand that they want a way to help, and they want to get out there and be in the trenches and help people, but they don't know how to leverage the technology to do it efficiently.
Yeah, I think that those are both great points. We did have another, thank you for that. We do have another question about whether or not you can speak to licensing in each state and how different it is and the barriers or hurdles related to state licensure or credentials per hospital.
Well, those are both topics that can take up a fair amount of time and energy and can be frustrating at times. But, and the policies around COVID care have relaxed some of those regulations, at least from the licensing side of things. But I'd say the macro trend that I see that's really helping providers do interstate telemedicine is the unprecedented cooperation we're seeing amongst state medical boards for licensing. And so the Interstate Compact is a prime example of that, where if you get licensed in a state that is one of the member states in that group, like I got licensed in Arizona, and it was very easy to get subsequently licensed in a ripple effect in Colorado, Montana, Minnesota. You just kind of move. You can move because there's 26 and I think and counting states that are currently agreeing to accept the vetting process of one state. And if your primary state of record says, oh, this is a good physician that has not had major problems with legal difficulties or with standard of care and things like that, and we vetted them and their background check is good and everything, the other states will say, okay, well, we accept that, and we'll basically grant a state license in our state, with whatever unique rules we might also require for CME and things like that, But it greatly facilitates the whole process of getting licensed in different states as needed for administering telehealth. So even if the regulations were to go back and become more restrictive again, getting the licenses has become easier than ever before. Regarding credentialing, I would love it if we could have some kind of a credentialing process that would be widely accepted by every facility that we talk to, and that's not where we are right now. So a JCO can accredit a practice, and you can use that to kind of vet the credentialing process a bit, but each facility is still going to want to maintain some direction over their credentialed staff and who they let into their facility to see their patients. So I can't see that going away anytime soon.
Good point. Thank you very much. I did want to give Jack and his team from Montana to talk about some of their efforts that they have underway or that have changed a little bit in Montana. I know Jack has a history or a background in telehealth as well. Jack or Montana guys, are you there? Star 2 will unmute your line.
Hey, Caleb.
Howdy.
I don't think I can probably add a great deal to what has been done. This is such a terrific session, and I picture what it would have sounded like pre-pandemic, because there's been a lot of us that have been working to implement telehealth for 20 years or so, and what has happened a little lately is that essentially all of the barriers to the implementation of telehealth have gone away due to the kind of the perfect storm of the pandemic, having the technology that can actually do this, because if it had happened 20 years ago, the technology would not have supported opening up telehealth like this, and then having the government come back and say, we're going to help you remove these barriers. I think probably one of the strongest comments I would make is that we as providers and flex programs, even though we can't fly, but I think the industry needs to make sure that we continue to advocate strongly that we don't go backwards when this has left. This is toothpaste that should not go back in the tube, and we need to hang on to as many of these these waivers as we possibly can, because they every day are proving the efficacy of telehealth. And what Dr. Steffen has been talking about is the culmination of what many of us have been trying to do for a very, very long time. Now, here in Montana, telehealth has been in Montana for a long, long time because of who we are and where we are, and it's as a service to people who live a long way from healthcare. But I think even for our smallest critical access hospitals now, this will be a new revenue source, a new access source, a way to extend providers, recruit providers. Just it's amazing and so ironic that such a horrible thing would cause such positive change for telehealth. And I agree with Terry completely. There's no going back from this. My hope as a flex director is that we begin to see with FORP and with National Flex and Flex Monitoring the kinds of projects. We're not going to be telehealth providers, but we can support critical access hospitals in their implementation and management of telehealth, and I'm looking forward to getting new guidance and new areas in our scopes of work to be able to do that.
Yeah, absolutely. I'll ask Andy to put up the polling questions as we kind of bring this webinar to a close. But I think Jack's made a lot of really good points there, guys. These are services that are being offered right now, and we don't know if they'll continue. So make sure your hospitals, if they are utilizing them, are doing so and sharing those successes and capturing some of those successes, so you can forward them on to whomever you need to share the outcomes of the beneficial waivers that have been brought, or just expanded care and exposure to that. I think all of those are beneficial things. Dr. Steffen highlighted a bunch of opportunities that telehealth as a whole can do, and Jack highlighted the need for those from the Flex program or from wherever to help your hospitals examine at the very beginning, but implement some of these programs beyond that. Antibiotic stewardship programs, that's something MBQIP has been tracking for quite a while, and there is a lot of benefit to hospitals as well as patients and communities that can come from just that one project that is very doable and easily helped with the help of a specialist. Not everything has to be an infectious disease specialist, but there are programs that can help the hospitals, even if you're not implementing telehealth for patient care. There's a lot that can be done. So as you guys continue trying to identify opportunities, please do let us know what we can do for help. task@ruralcenter.org is our email address. The slides from both May as well as Dr. Steffen can be found on the bottom left in the files spot there. If you have any additional questions, please don't hesitate to ask. And we have a Task 90 webinar on the 13th, which is focused on coronavirus and all things COVID. So we'll hear updates from the National Rural Health Association, from NOSOR, from the Hospital Association, as well as other partners next week on May 13th. So please do join us for that. I would like to thank May Kwong, the Executive Director from the Center for Connected Health Policy, and Dr. Kevin Steffen from NOD Specialists for presenting today, keeping us up to date on the waivers and information related to telehealth, as well as just educating us a little bit about that. We really do appreciate it. Thank you both.
Thank you for coordinating and organizing such an excellent webinar.
Great. Thank you very much. And if anybody has any further questions, let's ask them now. Otherwise, thank you very much for your time. We know how busy you are and like to bring you beneficial educational content.
Bye, everyone.
Thanks, guys.
This conference is no longer being recorded.